Thank you for having me. I'm Biraj Neupane. My thesis topic is cardiometabolic risk factors among rural and non-rural adults in Nepal. So I like to start with the background. The term cardiometabolic disease refers to a group of conditions that involves both cardiovascular and metabolic disease disorders categorized within non-communicable disease, which shares common risk factors. So NCD accounts for 71% of all deaths in the year 2016. So the prevalence of cardiovascular diseases has been increased from 5,068 per 100,000 population in 1990 to 6,661 cases in 2019. Similarly, the prevalence of diabetes and chronic kidney disease has been increased from 8,355 per 100,000 in 1990 to 12,840 in 2019. Death from cardiovascular disease, chronic kidney disease, and diabetes in Nepal nearly doubled from 1990 to 2017. In 2019, cardiometabolic disease were the leading cause of death, with 21.5% being CVD and 4.4% being diabetes and chronic kidney diseases. So the specific aim and significance of our studies are as follows. Low and middle income countries have witnessed a significant rise in cardiometabolic disease, whereas high income nations where they have either seen decrease or stabilized in past 50 years. In this study, we aim to better understand the major conventional risk factor for cardiometabolic disease in rural and non-rural Nepal, as they have not been studied well. In this study, we plan to determine the prevalence of demographic and lifestyle-related cardiometabolic risk factor in rural and urban population, assess association between demographic and lifestyle-related cardiometabolic risk factor with BMI and hypertension among rural and non-rural adults. So in terms of methodology, our non-rural populations are 18 years and older living in Dhulikhel municipality. And for our rural population, 18 years and older living in 4 designated area of Dhulikhel Hospital Outreach Center. So our study design is cross-sectional study of data merged from Dhulikhel Health Study for non-rural population and personalized health program data for rural population. In terms of sample size, our total sample size is 4,349. For urban, we use the DHS Wave 2 data, and till March 2023, we had 1,061 participants who were 18 years and older. And similarly, in PHP program, 3,288 participants were enrolled who were 18 years and older from 4 sites. I'd like to give you a brief summary about both projects. Dhulikhel Health Study was created in 2013 to study the prevalence and risk factor for cardiovascular disease in adults living in Dhulikhel, Nepal. The initial survey took place between 2013 and 15. The second wave took place between 2022 and 23. So personalized health program, which is also called PHP, is an extension of healthcare service in which community-based household level data was collected. PHP is based in 4 rural sites of Nepal: Manikharka, which is in Sindhubalchok district; Dorpu is in Solukhumbu district; Thansing is in Nuwakot district; and Bolde is in Kabra district. First wave of rural community-based population level data was collected in 2022. So in terms of statistical analysis, Strata 13 was used for data analysis. The proportion of demographic and behavioral lifestyle risk factor were separately analyzed in rural and non-rural population. Demographic and risk factor data are described with continuous variables presented as mean and standard deviation, and categorical variables presented as count and percentage. Our outcome variables are defined as obesity being more than or equal to 25 and hypertension being systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90 mm of HGA. We use European Society of Hypertension and Cardiology guideline. Multivariate logistic regression was used to evaluate the association between urban versus rural residency and study outcomes. The adjusted odds ratio is calculated to examine association between the main exposure and the outcome of obesity and hypertension. The result of this analysis are presented in odds ratio with 95% confidence interval. The hierarchical models for adjustment are shown in unadjusted model, adjusted for sociodemographic variable and adjusted for sociodemographic and behavioral lifestyle variables. So baseline information of our study participants are as follows. 44.47% of the participants were male, whereas 55.37% of the participants were female. The mean age of our study participants was 45.66. So outcome variables, we can see our outcome is for obesity is defined as BMI being more than or equal to 25. In rural, there were around 35% of the people who were obese. And in urban areas, there were more than 50% participants who were obese. And the mean BMI of the total participants were 24.58 with 4 standard deviation. So in this slide, we can see the urban residency had 2.03 odds of being obese without any adjustment, with meaning that the individual living in urban areas have 2.03 times odds of experience the obesity outcome to individual living in rural areas. Sorry. And similarly, urban residency adjusting for demographic and lifestyle is 2.14 with 95% CI of 1.57 to 2.93. The p-value is less than 0.001, indicating a significant association. In summary, living in urban area is associated with increased odds of being obese compared to living in rural areas. So our second outcome is hypertension, which is defined as systolic blood pressure being more than or equal to 140 or diastolic blood pressure being more than or equal to 90. In this model, we can see 2% of the urban residents were hypertensive, whereas 25.55% of the rural residents were hypertensive. So in this model, we can see the odds of urban residency is 1.19 with 95% CI of 1.02 to 1.39. After adjusting for demographic, the odds ratio for urban residency increased to 1.27, suggesting that the association between urban residency and hypertension persists even after accounting for demographic variable. Further, when we adjust for demographic and lifestyle characteristics, the odds ratio for urban residency increased 2.12. P-value remains less than 0.001, indicating a highly significant association between urban residency and hypertension. So, in summary, these results suggest that living in urban area is associated with an increased likelihood of hypertension compared to living in rural areas. So, one of the study done in Ghana found 44% of individuals who spend their childhood or adult life in urban environment were obese. Similarly, other studies have consistently demonstrated higher obesity prevalence among women compared to men. Our study further supports that urban residents increase the odds of being obese, and women have higher obesity odds than men. Our Ghanaian study found no significant association between residents and hypertension. Whereas a systematic review in South Asia observed a higher hypertension prevalence among men compared to women. We found a significant association between urban residency and likelihood of hypertension and higher prevalence among men. So concluding our research finding indicates a significant association between urban residency and higher prevalence of obesity and hypertension, even after adjusting for demographic and lifestyle factor. Finding highlights a higher prevalence of obesity among women and among individuals with higher education level. Older age is identified as risk factor for both of our study outcomes, obesity and hypertension. We found a higher prevalence of hypertension in males and identified certain ethnic groups as being associated with increased risks of hypertension. These findings highlights the importance of focusing urban residents, gender, education, age, and ethnicity as key factor in the prevention and management of cardiometabolic conditions. So I'd like to acknowledge my chair mentor, Professor Anit, my mentor, Dr. Archana Shrestha, my mentor and committee members, Dr. Biraj and Dr. Chris Longnecker, University of Washington, Dulikela Hospital, Kathmandu University Hospital, Cardiometabolic Research Training Program, NIH, DSS team members, PHP team members, Department of Global Health, my friends, family, and colleagues. These are my few references. Thank you.